Pacific Islander Community Association have stepped up to help reach the communities that they serve. We also have to make sure tools are accessible for everyone. For example, if they have a disability that makes an online sign-up process difficult for them, or if they don't have access to the internet or a mobile phone, or if they have limited English proficiency, we have to make sure that vaccine doses get to care providers in hard-hit and hard-to-reach communities. That is why I've been working really hard for critical investments in vaccine equity in the American Rescue Plan that we just passed. As you know, last week, the Biden administration announced over $10 billion for vaccine funding that I was able to get would be used to address vaccine equity, with over $200 million going to health centers here in Washington State. The administration has also set up a program to distribute vaccines directly to 950 community health centers. 23 community health centers in Washington State have now been invited to participate in that. And those centers are really a lifeline to millions of families that may not otherwise have care close to their home. So that's why that's so critical. So we have a lot of work left to do to end this pandemic and get everyone vaccinated. And I have this discussion today so I can hear what's working, what's not, what's going on, and make sure we are addressing this continually as we try to end this pandemic. So again, I want to thank all of our panelists who are here. We look forward to what you have to say. And Dr. Chen, we will begin with you.
Thank you, Senator Murray. At this stage in the pandemic, public health officials are balancing messages of caution and hope. After seeing a decline in COVID-19 cases, we're starting to see cases rise. Here in Pierce County, the COVID-19 case rate has increased by about a quarter in the last 2 weeks. The next time that we're going to be evaluated for the Roadmap to Recovery, the Healthy Washington Roadmap to Recovery, will be in April, about mid-April, and we believe the 14-day COVID-19 case rate for Pierce County is likely to exceed 200 per 100,000. And the 7-day new COVID-19 patient hospitalization rate is likely to be above 5 per 100,000 on April 12th. So we're really concerned that this may mean that we, Pierce County, may have to move back from phase 3 to phase 2. But I think this is something which everyone can help us with, and I'm sure this is what other counties are seeing as well. And you know, we're just seeing that even though our rates now are lower than the really high peak at the end of last year, they're still much higher than they were in the spring and summer. Obviously, this is not welcome news, but you know, we continue to ask for everyone's help in wearing their masks, you know, restricting their activity. And, you know, we're concerned with spring break coming up. I think people have seen the pictures from Florida where people are just in big crowds, not wearing masks. They're obviously very tired of having had COVID for a year, but we still need to keep our defenses up and continue to do everything that we need to do while we continue to vaccinate people. Senator, thank you and other members of Congress for passing the American Rescue Plan. These are, it's definitely a big help for us. It will provide critical aid in the fight against the COVID-19 pandemic. It will support our contact tracing, our case investigation of public health nurses, our epidemiologists, our community health workers, and other essential workers to control and prevent COVID-19. Most importantly, as you mentioned, the ARP will help us close gaps on vaccine equity. What you've mentioned regarding the racial ethnic disparities, we're definitely seeing here in Pierce County. The Pacific Islander population is 4 times as likely to get COVID-19 as the white community, and Black, Native American, American Indian, and Latino communities are more than twice as likely. But even where they live, we know census tract data shows us that those who live in the least advantaged areas were 50% to 100% more likely to be infected with COVID-19 than those living in the most advantaged areas. And they're also less likely to receive vaccine. There are many other factors. I mean, not everyone drives, not everyone's mobile, not everyone's comfortable using technology to register for a spot at a vaccine clinic. Not everyone speaks English. And so some people benefit from other settings or having other ways. And that's why the Tacoma-Pierce County Health Department is taking a multi-strategy approach to close gaps in vaccination. We're working hard to make sure that COVID-19 vaccine gets to everyone in Pierce County who's eligible. We're relying on the credibility of community leaders where mistrust and suspicion exists. Over the last 3 months, we've offered many different paths to get vaccinated. Our most effective tool is bring vaccine to people where they live. In fact, today in our auditorium, and we're kind of located close to the Lincoln District here in Tacoma, we have what we call a pop-up or community-led clinic to serve people in our neighborhood. And we've also done this in the Hilltop neighborhood and east side of Tacoma, many other areas in Tacoma and Pierce County. And our equity-informed approach dovetails with the Department of Health's priority on equitable vaccine distribution. This equity support obviously needs funding, and that's where the ARP really will help out. And my hope is that through these efforts, COVID-19 cases will decline in our county, state, and across the United States. But as I mentioned, the rates are going up right now. We've also heard several other states have what I think is prematurely lifted their restrictions, including masking mandates. So thankfully, Washington is in a better circumstance. We still have guidance that keeps us safer. And let's be cautious not to let optimism translate into making the wrong choices. So with that, I want to turn it over to Dr. Allison Berry.
Thank you, Dr. Chen. I actually grew up in Pierce County, so I always feel a closeness to what you guys are doing there. So thank you for having me here. I wanted to speak a little bit about what we've been doing in Clallam County. In rural Clallam County, we have very few resources, but we have done quite well in the vaccine distribution. And one of the primary foundational drivers of that has actually been our early commitment to equitable distribution of vaccine. From our very first box of Pfizer that arrived, we knew we didn't have enough for all of our healthcare workers. And so we called together a meeting of our healthcare leaders along with the public health department and decided amongst ourselves that any vaccine that comes into Clallam County belongs to all the people of Clallam County. And so we took that box, which came to an individual healthcare entity, and we broke it up and rapidly distributed vaccine throughout the county so that every ER nurse in the county had the same access to vaccine, regardless of where they work and regardless of who they know. We then kind of sub-tiered healthcare workers and moved vaccine through each of them every time we got an additional box. And we've been doing that ever since. And so it actually, that early commitment to equity, even among healthcare workers, actually helped us move through that tier faster, so that when it became time to move to 1B, we were already done. And so we could just move on to the next tier quite quickly. The other thing we did was, because we have a tiny health department, we have basically 5 medical personnel who work for us, we have to rely on our community to get this done. So we have partnered with our healthcare personnel throughout the county and really leveraged those partnerships to create mass vaccination sites from the very beginning that were staffed by a wide variety of medical professionals and volunteers from our community. That freed up our very tiny but very dedicated public health staff to do direct outreach. So for instance, last week, our team, including myself, were vaccinating at a trailer park in Forks to help make sure that everyone had access to vaccine. Specifically, we were vaccinating undocumented farm workers, were really our primary target in that group. So it's freed up our staff to do those kind of less large scale outreach, but very targeted to reach communities who we know would otherwise struggle to access vaccine. We're going to be going to a food bank next week. We've been doing a lot of those kind of more creative things while we rely on our healthcare partners to staff our mass vaccination sites. The other thing we did really early was we noticed that there were tiers of folks who were very high risk, very high need, who were not tiered very high. So people who live in shelters, people in prisons are tiered now. We're just supposed to be getting to them now. We didn't think that was just, but we can't change the tiers. And so what we did was we took, people might or might not know, at the end of most vaccine events, you have a few extra doses, 2 to 30 extra doses at every event. What we've been doing is ever since our first event in January, we take those those, and we take them directly to the people who are not tiered high, but who need them. So we've been taking them to the prison, we've been taking them to the shelters, we've been taking them to the Oxford houses, and all throughout the community. And so, it doesn't sound like much, but if you do it every day, it goes a long way. And so we're supposed to have just hit B4 now, which would hit folks in prisons and shelters, and they're already done. Our shelters are already vaccinated, and they've been vaccinated one day at a time. So we've had to get creative to get that done, but that early commitment has made a huge difference, not only in our ability to reach these hard to reach populations, but our ability to move through the tiers quite quickly. We've had to get creative to get it done, but so far it's been really working quite well. And last, but very much not least, I just want to acknowledge one of our major strengths has been our partnerships with our neighboring tribes. So we have quite a few neighboring tribes in our area, and so we have been partnering with them throughout the COVID-19 pandemic, partnering on contact tracing, on outreach around the virus, and so we already have strong existing relationships with our neighboring tribes when we got into the vaccine distribution space. And one of the most incredible things to witness has been how our tribes have stepped up to vaccinate their populations. They have done an incredible job. So the Makah tribe, for example, has vaccinated 80% of their population. They're basically done. Jamestown tribe has done the same. And then the Jamestown tribe really stepped up to put the pressure on all of us to move faster. They said, we've done great. We've finished vaccinating our tribe. How can you move faster? And how can we help? And so they have stepped up, built one of our largest and most efficient mass vaccination sites, and they have actually agreed to vaccinate non-tribal citizens. So they've vaccinated approximately 30% of Clallam County's vaccine that has been distributed has been by the Jamestown tribe. I think we often think of the tribes as a group that may need our help, and I think one of the things that we need to acknowledge is that our neighboring tribes have actually been a source of wisdom and learning and strength for how we can do better in vaccine distribution. And so it has been an incredible privilege to partner with our neighboring tribes to move vaccine in our community. And we are excited to keep doing that. And so with that, I will pass over to Administrator Davies.
Thank you, Dr. Berry. Often when we discuss health inequity in the United States, we have a myopic view of what that means. We often treat each community as if it exists in an isolated bubble, that these problems are inherent in our systems and that they're too complex to change. Each system works as it was designed to work, whether that design is intentional or accidental. Our systems are historical as well as present. They are iterative processes handed to us by our predecessors, and these systems are connected globally. Regardless of how these systems function, there exists structural violence. Structural violence is the passive harm inflicted on people through unequal or inequitable systems. This current pandemic we are experiencing brings that into sharp focus now more than ever. COVID-19 doesn't respect borders and has disproportionately affected marginalized populations. COVID-19 is just one of the major global challenges facing us. We have to build resiliency in our marginalized communities in order to weather future crises. When I step back and view this from a pragmatic perspective, health inequity is expensive. It is expensive to our populations who bear the burden of disease, to our health systems, and to our larger communities. It is worth the investment in changing our structures and systems to increase access to education, services, and care, and reduce structural violence within public health. The cost of these investments include time, human resources, fiscal, and political capital. These costs pale in comparison to the cost our communities who experience the highest levels of morbidity and mortality pay. While it is hard to address complex problems, that doesn't mean that we should give up. To me, that means that we have to work together to break down the complexity to remove the inherent structural violence. I grew up in Chelan-Douglas Health District, in a small farming community surrounded by migrant workers and laborers. The structural violence experienced by many people in poverty was something that my family experienced in a lesser degree compared to my friends and peers whose families had barriers to language, education, and health, to name a few. It has been my goal as the new health administrator to use this current pandemic to bring about substantial change in the way that my health district and our local providers address the health issues of our Latinx and marginalized populations. We have worked hard with limited resources to partner with our local organizations to remove or circumvent barriers due to language, education, transportation, and technology in order to deliver the vaccine equitably. We want to do our best to bring vaccine to the populations who have the most barriers where they are. This isn't something that we can do alone, and we will continually need to improve. Our outreach teams are currently working on vaccine registration and education with local community-based organizations such as CAFE and our clinical partners. We have an opportunity to address the complexity to develop new structures and change older ones to remove the barriers I've mentioned. My goal in working with our equity partners is to bring forward the populations that have been historically invisible or unseen due to structural violence inherent in our systems. We cannot risk losing this opportunity to make long-standing investments and changes to how we address health inequity locally, as well as nationally and globally. And I want to thank Senator Patty Murray for her infrastructure bill. And with that, I'll hand it back to Amir.